When blood triglyceride levels climb too high, they can pose serious health risks, ranging from acute pancreatic inflammation to long-term cardiovascular disease. Understanding these dangers, their causes, and effective management strategies is crucial for maintaining overall health. A recent discussion highlighted 5 key pearls for navigating severe hypertriglyceridemia, offering insights into its mechanisms and treatment. One of the most immediate and critical concerns with elevated triglycerides is the risk of acute pancreatitis. This risk surges dramatically once triglyceride levels exceed 500 milligrams per deciliter. This happens because the body's primary enzyme for breaking down triglyceride-rich lipoproteins, called lipoprotein lipase, becomes saturated. When this enzyme can no longer effectively clear large lipid particles, like chylomicrons, these particles build up. They can then physically obstruct tiny capillaries within the pancreas, leading to a cascade of events, including ischemia, the premature activation of pancreatic enzymes, and a severe inflammatory response, all culminating in acute pancreatitis. Beyond the acute threat of pancreatitis, high triglycerides also significantly contribute to a patient's overall risk of atherosclerotic cardiovascular disease, or ASCVD. In fact, triglyceride levels persistently above 150 milligrams per deciliter are considered an independent risk factor for ASCVD. What's more, for those with elevated triglycerides, standard LDL cholesterol measurements might actually underestimate the total burden of harmful atherogenic lipoproteins in their bloodstream, giving a false sense of security regarding their cardiovascular health. An important step in managing hypertriglyceridemia involves diligently searching for and addressing potential secondary causes. Many conditions and medications can dramatically raise triglyceride levels. Common culprits include poorly controlled diabetes mellitus, where insulin resistance impairs lipoprotein lipase function, along with hypothyroidism, nephrotic syndrome, obesity, and excessive alcohol consumption. Certain medications are also notorious for this effect, such as glucocorticoids, high-dose thiazide diuretics, non-selective beta blockers, oral estrogens, and atypical antipsychotics like olanzapine and quetiapine. Addressing these underlying factors can sometimes be enough to normalize triglyceride levels and even eliminate the need for dedicated lipid-lowering therapy. For patients presenting with severe hypertriglyceridemia, often defined as levels over 1,000 milligrams per deciliter, or those already experiencing acute pancreatitis, inpatient management becomes essential. The initial focus centers on placing the patient on NPO status, meaning nothing by mouth, to eliminate all oral intake of fats. This simple intervention alone can remarkably reduce triglyceride levels by as much as 50% within the first 24 hours. Aggressive intravenous fluid hydration is also crucial to either treat existing pancreatitis or prevent it from developing. An insulin infusion can be particularly valuable, especially if hyperglycemia is also present, as insulin enhances lipoprotein lipase activity and suppresses the release of free fatty acids. In very severe or refractory cases, plasmapheresis can serve as a rescue therapy. It works by physically removing chylomicrons from the blood, offering a rapid, though invasive and resource-intensive, reduction in triglyceride levels. When it comes to long-term management and preventing pancreatic risk from persistently elevated triglycerides, specific oral agents and profound lifestyle changes come into play.
Fibrates are considered the most potent oral agents for this purpose. If triglyceride levels remain above 500 milligrams per deciliter despite initial lifestyle efforts, fenofibrate is often the first-line therapy. Fibrates work as PPAR-alpha agonists, boosting the synthesis of lipoprotein lipase and enhancing fatty acid oxidation. Their role in mitigating pancreatic risk is undisputed. It is important to avoid combining gemfibrozole with statins due to a significantly increased risk of myopathy. However, no pharmacological intervention can replace the power of lifestyle changes. Strict avoidance of alcohol and refined carbohydrates is paramount, as both are readily converted to triglycerides in the liver. A low-fat diet, a weight loss of 5 to 10% of body weight, and regular aerobic exercise are also highly effective. These lifestyle modifications, when implemented consistently, can often lead to reductions in triglyceride levels of 50% or even more, profoundly impacting both acute pancreatitis risk and long-term cardiovascular health. In essence, managing severe hypertriglyceridemia requires a multifaceted approach. It starts with recognizing the acute risk of pancreatitis and the long-term threat to cardiovascular health. It demands a thorough investigation into secondary causes, effective inpatient management for severe cases, and a strategic combination of potent oral agents like fibrates with sustained and significant lifestyle modifications. By understanding the intricate mechanisms and employing these targeted interventions, clinicians can significantly improve outcomes for patients facing this complex lipid disorder.